Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. This briefing will feature leading experts who will discuss the challenges in trying to achieve full vaccine coverage in the US, especially as racial and economic differences continue to divide the vaccinated from the unvaccinated. They will discuss potential approaches for increasing vaccine uptake, particularly among vaccine hesitant and vaccine averse populations. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. First, I'd like to briefly introduce our two speakers. Dr. Lisa Cooper is the James F. Fries Professor of Medicine and a Bloomberg Distinguished Professor in Health Equity at the Johns Hopkins Bloomberg School of Public Health and Schools of Medicine and Nursing. She is also the director of the Johns Hopkins Center for Health Equity. Dr. Cooper studies how race and socioeconomic factors shape patient care and how health systems with communities can improve the health of populations with complex social needs. Dr. Cooper is the author of the forthcoming book, Why Are Health Disparities Everyone's Problem? Dr. Rupali Limaye is a social and behavioral scientist and health communication scholar in the Bloomberg School's International Health Department. She serves as the Director of Behavioral and Implementation Science at the International Vaccine Access Center. She is co-author of a book titled The Clinician's Vaccine Safety Resource Guide, Optimizing Prevention of Vaccine Preventable Diseases Across the Lifespan. We will have time for questions following our panelists' remarks. The procedure will be as follows. We will take some questions that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question during the briefing, you can enter in the Zoom chat addressed to all panelists. Please enter your name, media outlet, and question. We hope to cover as many as possible. Just a note that participants will be muted during this briefing and it will be recorded. Dr. Cooper, please go ahead.
Thank you. Good afternoon, everyone. It's a pleasure to be with you this afternoon. I'm a physician trained in internal medicine and a public health researcher, and my field of research is health disparities. So the inspiration for my work comes from my experiences growing up in Liberia, West Africa. It was there that I first realized how opportunity and privilege, or the lack of those things, actually shapes the course of each person's life. Health disparities are avoidable or unjust differences in health within and between countries among social groups with different levels of wealth, power, or privilege. These groups are defined by race or ethnicity, gender, income, geographic location, or physical or mental abilities. And many people don't realize this, but an estimated 265 daily deaths in the US are actually attributable to racial and ethnic health disparities. That's the equivalent of a 747 crashing every day. Health disparities are widespread across geographical regions. They impact people of all ages. They cause premature deaths, reduce quality of life, and they cost billions of dollars each year in our country alone in medical expenditures and other costs associated with lost productivity. And as you all know, the COVID-19 pandemic has shown a magnifying lens on these disparities. A disproportionate number of the cases, hospitalizations, and deaths from COVID-19 have been among people of color. And even as COVID-19 vaccines have become available, there remain inequities in access to them by race and ethnicity. And although half of American adults and those aged 12 or older are now fully vaccinated, many people living in middle and low-income countries such as India and many countries in Africa and Latin America will not have access to a vaccine until next year or later. Here in the US, vaccination rates are lowest among African Americans and Latinos and across several southern states. There's also a myth that the poor health that's experienced by many socially disadvantaged groups is the direct result of negative attitudes and poor choices made by individuals. But actually, because of centuries of discrimination and social injustice, Many people in those communities experiencing health disparities don't want to be unhealthy, they just lack opportunities to make healthier choices. Currently, I direct the Center for Health Equity here at Johns Hopkins, which my colleagues and I established 11 years ago to address disparities in chronic medical conditions such as high blood pressure, heart disease, diabetes, and chronic kidney disease, which are leading contributors to racial and income disparities and mortality worldwide. And our research has focused on developing practical and sustainable solutions to health disparities. We've identified effective programs to improve consumption of healthy foods among people living in food deserts, to enhance patient-physician communication in primary care settings, and to improve blood pressure control among persons of color and persons with low income. We've trained over 4,000 researchers and practitioners globally, and we've really established a robust community academic partnership. This is critically important because, as we know, these partnerships help us to build trust with communities that have many reasons to distrust science and medicine. Our partnership includes people from community and faith-based organizations, neighborhood groups, and people from healthcare, education, public health, and a number of different sectors, as well as policymakers. These individuals really help us identify the most relevant questions. They make sure our work is grounded in lived experiences of people, and they make sure that everyone has some skin in the game for addressing health disparities. So in my forthcoming book, Why Are Health Disparities Everyone's Problem?, what I hope readers will take away is these main points. First, everyone's health is interconnected within communities and across the globe, and none of us will be able to remain healthy until we're all healthy. Second, equality or giving everybody the same thing is not the same as equity. To achieve equity, we must give to each person or group according to what they need. Third, achieving a healthier and more just world will require changing individual attitudes and behaviors, improving relationships across race and social class, as well as dismantling the structural factors, such as our organizational practices, laws, and policies. And finally, we can each play a role in achieving this vision. So I look forward to achieving and discussing these topics with you in greater detail during our conversation today. Thank you.
Thank you, Dr. Cooper. Now we will hear from Dr. Limaye. Dr. Limaye, please go ahead.
Thank you so much. It's great to be here today. I'm a behavioral and social scientist, and I've been studying vaccine behaviors for almost 10 years now, and specifically related to vaccine disparities. Over the last year, I've been working closely with African Methodist Episcopal churches, having met with more than 250 pastors and more than almost 1,000 congregation members to better understand vaccine hesitancy. I'd like to start off with just a few comments related to vaccine coverage. So in the US, we're now at a point in vaccine coverage where it's really important to try to address and mitigate vaccine hesitancy. Until now, for the most part, we've been getting shots in arms easily, essentially meeting demand for vaccines. But we are now at the point where it will take some persuasion to nudge individuals that have still not gotten a COVID-19 vaccine. Vaccine behaviors lie along a continuum. We have a set proportion of individuals here in the United States that accept vaccines. We also have a small subset of individuals that fundamentally and philosophically oppose vaccines. We also have a segment where there are individuals that are unsure about whether or not to get a vaccine. Currently, vaccine coverage by state varies quite widely, and just this week, the Biden administration announced that they will not meet the goal of having at least 70% of adults with one dose by July 4th. While certain states have already met this target, we know that there are several states, particularly in the South, that are really lagging in coverage. And so until we can get vaccination rates up across all states, the United States will continue to be at risk for outbreaks. We're really seeing hesitancy now in specific populations, specifically within populations that have health disparities related to COVID morbidity as well as mortality. And this is really due to a lack of confidence in the vaccine, concerns about safety related to the vaccine, as well as distrust in government. And so to reduce vaccine hesitancy, there are several key strategies that we need to think about. These are focused on first meeting people where they are with regards to messengers, messaging, as well as access. So first, it's very important, as Dr. Cooper mentioned, to really identify trusted leaders within communities. These can be faith-based leaders, these can be community leaders and business leaders, and we need these individuals to encourage their peers to accept the vaccine. Second, several states are trying many different innovative approaches to persuade adults to get a shot. Vaccine incentive programs, for example, should really align with general behavioral principles, meaning by meeting people where they are. Some people may be nudged by a free donut. Others may require something larger, such as a chance for a college scholarship, for example. Even an increase of 1% to 2% of vaccine coverage at the state level could really limit outbreaks. Third, to reach more communities that are underserved, a one-dose option should be promoted and can really help close the coverage gap. As such, the Johnson & Johnson product here in the United States should not only continue to be promoted generally, but specifically within populations. Fourth, there are many things that workplaces and employers can do to increase vaccine coverage here in the United States. They can serve, for example, as distribution centers for vaccine delivery and rollout, but they can also give employees time off to make sure that they can get the vaccine. Finally, there has been an increase and an uptick in anti-vaccine organizations and their movements over this last year. There is concern now that there's a growing following behind this anti-vax movement, and that's why the role of journalists is so important. Journalists can continue to focus on strong communication that does include ensuring that headlines are not sensational, that messaging is not only clear, but includes a call to action, and that the messenger is trusted and credible. Thank you so much.
Thank you, Dr. Limaye. Now we'll take questions. If you have a question, a reminder, please enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. First question is from Aaron Durkin at National Journal for both Dr. Cooper and Dr. Limaye. What do you think the White House and Congress should do next to help get more people vaccinated? Let's go with Dr. Cooper first.
Sure. I think there's a lot that the White House and Congress can do to continue to assure that more people continue to get vaccinated. First of all, I think people in positions of leadership are influential in many ways. They have been elected and are trusted by many people, so they can be role models and they can deliver messages around the safety of the vaccine and its importance, especially at this time with the Delta variant increasing in prevalence. So I think really having leaders that are out front and speaking out about the importance of this does matter. I think also the funding that's been put towards building up the public health infrastructure and strengthening partnerships around increasing vaccine access are very important to continue to support those efforts and to work closely with those who are local leaders who are working on efforts within their jurisdictions. So I think there's a lot that can be done. I think a lot has been done, but I think we need to not let up, because even though we have a very high proportion of our population vaccinated, we still have, as Dr. Limaye said, pockets of our population, including ethnic minorities, particularly African Americans, and then people across geographic regions who remain unvaccinated due to concerns around either the vaccine itself or around access and distribution issues.
Dr. Limaye?
To add on to Dr. Cooper's point, I think because the biggest issue for me is an access issue, if we think about this through a disparities lens, the individuals that are still wanting to get a vaccine but are not able to get a vaccine, that really lies in distribution. And so one thing that government and state governments can do is to ensure that there are innovative distribution channels where you're meeting people where they are, whether that's at the community level, so doing pop-up clinics, ensuring that employers can allow for vaccine distribution will go a long way to reduce disparities and increase coverage at the same time.
Great, thank you so much. Here's a question from Jenna Portnoy at the Washington Post for Dr. Cooper. How have efforts to boost vaccination rates changed now that the infection rate is down?
So, what I would say is that, as far as I am aware, efforts to boost vaccine rates are still ongoing and are very strong, particularly in communities of color. I am the co-chair of a steering committee for a large NIH effort called SEAL, which is Community Engagement Alliance Against COVID-19 Disparities. And in that effort, we have 23 community academic partnerships, 23 teams across 23 states that are really still working in those disadvantaged communities to make sure we get the vaccine rates up, whether it's due to enhancing literacy around the vaccine, using the trusted messengers, as Dr. Limaye mentioned, working with community-based organizations who actually are well known and do know where people are and know what their concerns are to deliver messages that they can understand and address those specific concerns. Those are ongoing efforts. I think there may be places around the country where efforts have declined, but for the most part, I think in our disadvantaged and inequitable communities, we're really still seeing a lot of efforts being made, fortunately, because we do need them. And I see a lot of faith leaders stepping up to the plate, offering their churches as places for vaccine administration, and really a lot of local businesses still working very closely with public health and with clinicians and health systems and researchers to make sure we get the word out and the vaccines out.
Great, thank you so much. Here's a question from Greg Angel at Spectrum 13 News for Dr. Limaye. The Florida Department of Health reportedly turned down 5.7 million doses of COVID-19 vaccine from the federal government because there wasn't a clear need, in quotes. What is the data seeing in terms of demand? Is there a drop-off? Is there reluctance? 5.7 million vaccines declined seems like a lot. How does this compare nationally?
So we have seen, starting when vaccine rollout started in December of last year, we essentially were having, all states, I would say, are actually having a challenging time meeting demand. Starting around April and May, when we started to hit, I think, a proportion of the population of more than a third that had been vaccinated, there started to be a drop off with regards to appointments being scheduled and information requesting related to vaccine appointments and availability. I think overall states were seeing a decrease in the amount of appointments and the amount of shots in arms on a weekly basis. The biggest issue I think that we are facing is that we do know in many states there are still individuals that are unable to gain access to the vaccine. Either they're unable to make an appointment, they're unable to get to a clinic or a location that is manageable and structurally available for them, or they still have questions and they need to talk to someone that's trusted scientist where they can figure out how they can make an evidence-based decision. And so this idea that over 5 million doses were essentially turned away is a real challenge, because we do know that there is still demand. It's just harder to reach those individuals, and states need to be much more innovative, as Dr. Cooper just mentioned, to really finding those individuals and reaching them and offering them, if they would like to get a shot, the opportunity to do so without access issues.
Great, thank you so much. Here's a question from Michelle Smith at AP for Dr. Limaye. Do you see lack of access or hesitancy as the bigger challenge right now? And on hesitancy, how much of it do you think is driven by misinformation, disinformation, as opposed to a lack of information?
Mm-hmm. It's a really great question. We know over the last year that social media has really fueled an increase in misinformation and disinformation related to COVID generally and the vaccine specifically. We also know through studies that a number of individuals are making decisions based on this misinformation. It is a real challenge. There is a subset of the population that is more susceptible also to misinformation and disinformation. And sometimes this couples with individuals that might have lack of access to the internet, for example, or might be already having issues talking to a trusted source about vaccines. And so it's a huge challenge. typically when we think about hesitancy, we don't think about it from an access point of view. We think about it from a space of confidence or safety concerns, for example. However, many of us that are in this space and have been studying this space during this pandemic would argue that access is leading to hesitancy. An example I can give you is that earlier on in the pandemic, many older individuals, because states were requiring older individuals or all individuals to gain a vaccine appointment online, gave up trying to get a vaccine appointment, and essentially led to distrust in the overall healthcare system. And so to me, they're closely intertwined. I think, like I said, fundamentally, when you think about the definition of hesitancy, it doesn't include access, but because of the situation in the pandemic that we're in, they're very, very entangled.
Thank you so much.
I just wanted to chime in or add on to that. One thing I would say is I think it's both and hesitancy and access are contributing to the lower vaccination rates among certain groups right now. But we have seen that attitudes, for example, among African Americans have actually shifted to be quite positive towards vaccines since last fall. So we know the acceptance rate for vaccinations is as high among African Americans as it is among whites. So that actually does suggest that access is really playing a pretty significant role in the lower vaccination rates. And another example I'll give is that I know when you talk about hesitancy versus access, is that I know of a friend of mine who actually took her father to get vaccinated at a community clinic who is African American and felt very welcome there because, you know, the people there were from a similar background. They're first generation immigrants from the Caribbean. And they were very welcoming and warm to her father and encouraged him that everything would be fine and he would do fine with the vaccine. And when she inquired about, she was not of age at that point in time, but she was a caregiver, about having to come back with him and wondering whether or not she could get a vaccine as well, they were open to having her be vaccinated. So one of the things she really brought about is a lot of people who have difficulty with access. It would be so much simpler if they could have family vaccination events, for example, where people wouldn't have to, you know, go back and forth or come at a certain time based on some other eligibility criteria.
Thank you, Dr. Cooper. And related to this for you, Dr. Cooper, a question from Jane Miller at WBAL TV. Did the initial eligibility criteria make it more difficult to reach Black and Latino communities?
Yeah, yes, actually, I do think it did that because the initial eligibility criteria were based strictly on age. And we know that on a whole, African American and Latino populations in this country are younger than whites. So as a result, if we targeted individuals over age 65, just statistically, we were going to be reaching a higher proportion of people people who are white versus those who are Latino or African American relative to their representation, you know, in the overall 65 population. So I think by making the eligibility criteria focused on age, we perhaps unintentionally disadvantaged our communities of color, which tend to be younger populations than the white population.
Thank you. Here's a question from Rich Mendez at CNBC for both panelists. How important is investigating the origin of COVID-19, zoonotic versus lab leak, to decreasing vaccine hesitancy and prevention of future outbreaks? We'll start with you, Dr. Limaye.
Sure. Yeah, happy to take that one. It's a great question, and I think it's important because it will be instructive. I think the thing that I would move away from is that it's not an opportunity for us to place blame. It's essentially an opportunity for us to strengthen healthcare systems and surveillance. And that's not only here, but that's globally. And so I do think that it's important to understand the ways in which we can prevent any sort of future outbreaks with such pathogens and new pathogens that have caused so much morbidity and mortality worldwide. But I do caution, I think it's important to make sure that it's forward-looking and that the recommendations from any type of investigation are really to strengthen the healthcare system.
Thank you. And Dr. Cooper?
I agree. I think it's always important for us to understand what the source of an outbreak has been, and so that we can try to put steps in place to mitigate such things happening again in the future. The concern is that, if it were to be determined that this virus did come from a lab or a leak or something like that, that it could actually raise mistrust of science and health professionals. So we, again, have to be very careful about not blaming, but actually looking for the source of the problem as a way of coming up with a solution, and not sort of assuming that things were done intentionally to bring harm to the population. So I think it's going to be really critical for scientists, regardless of what the outcome is of this investigation, to communicate the implications of it very clearly to the general public.
Great, thank you. Here's a question from Stephanie Ines at the Arizona Republic for Dr. Limaye. Many of our readers in Arizona say they aren't getting vaccinated because they already had COVID-19 and therefore are immune. Do you have any opinions, scientific evidence to suggest that people who have had COVID should still be getting vaccinated?
It's a really good question. The current recommendation essentially suggests that even if you have had COVID-19 infection in the past, that you should still get vaccinated. And that's essentially, you should wait 90 days. The reason that that recommendation is put in place is that it's unclear how long your immunity will last after a natural COVID-19 infection. We know much more about how long immunity lasts when we're thinking about the vaccine-induced immunity compared to natural immunity. And so that's why it's still important to continue to message to folks that even if they've had COVID-19, that they should still get a shot. It's to protect not only themselves, but also their family members and their communities.
Great, thank you so much. Here is a question for Dr. Cooper. Post-pandemic, how will racial health disparities more broadly continue to play a role in public health and access to healthcare? Have we learned any lessons on the need to address such disparities during COVID-19?
Thank you. Yes, I think that those of us that have worked in the area of health equity and health inequities have known for a very long time that they are critically important and that they do impact a number of different important outcomes for all of us. Health inequities actually increase costs to our entire society. They result in loss of productivity and competitiveness on an economic level. They result in a lot of community disharmony and stress and civic unrest. In addition to causing a huge burden of human suffering. So we know that health inequities are bad for everyone, but I think that we know even more now how much it impacts everyone because we've seen how interconnected our health is. The fact that frontline workers and people from disadvantaged communities were infected at such high rates and hospitalized at such high rates really led to the pandemic lasting much longer and to us having to be on lockdown much longer, our kids having to stay home from school. So now we've really seen how inequities affect us all. And I think that hopefully this will have been a wake-up call for us and that it's not something that we go back to just functioning normally when this is all over, but keep in mind that addressing these negative social factors is part of healing our entire society. So it's not only about biological immunity, but I've used another term that I call a new kind of herd immunity, which is immunity and protection against negative social factors. So things like not having access to safe housing or a livable wage and healthy food and access to healthcare and access to a good education and a good job. So we really need to pay attention and make sure that everyone in our society has opportunities to attain those basic ways of having a good life, a good quality of life, because if not, as we've seen from this pandemic, it has a negative effect that ripples across all of us.
Great, thank you so much. And to conclude, a question for both Dr. Cooper and Dr. Limaye. Which populations in the US still need to be reached with vaccines, and what's contributing to the division between the vaccinated and unvaccinated? What role does access to vaccines play? Dr. Limaye, want to start?
Sure. So across states, there's several segments of the population. As Dr. Cooper mentioned, there are still stark disparities, racial disparities, where we're seeing lagging rates, especially in communities of color, African Americans and Hispanic populations in particular. So that's one. The second piece that we're starting to see, if we're looking at attitudes and we're looking at essentially vaccine intentions across different political ideologies, we do know at this point that individuals that typically are white and might be leaning more Republican or conservative are less likely to accept the vaccine. This is also true of this population that might have less than a college education. So there's a number of different segments, I would argue, and this varies widely by state. I think the key here is how to, again, to the point that I made earlier, how do we really meet people where they are? So that is not only with regards to provision of the vaccine itself, but provision of information so that they can make an evidence-based decision. As I also mentioned, one of the issues that we are seeing is that those individuals that still are unsure about a vaccine might also likely be susceptible to misinformation. So it's not only about access to a vaccine and reaching them, it's also making sure that they're having access to information that is evidence-based, again, from a source that's trusted so that they can make this decision in good faith.
Thank you. Dr. Cooper?
I agree completely. I think it's really important for us to identify who are the trusted messengers for different groups of people. We might make assumptions about who might be a trusted messenger, but that it might not actually be the messenger that we think is trusted for a particular group, for young people, for example, or for people who are from a different background, an immigrant background. So, for example, we've seen that faith leaders are highly trusted in African American communities, but in other communities, it may be that there's more concern around that, and people might actually want to hear from their own physician. And we've seen that actually the majority of the population says that their most trusted voice is the person that they would follow their advice is their primary care physician. So we need to learn more about which messengers are trusted for whom and what type of messaging works best. Generally coercive messaging and fear-based messaging we know doesn't work very well. And so having more of an open approach to understanding what people's concerns are and then addressing those concerns specifically. So tailored approaches are going to be needed.
Great. Thank you, Dr. Cooper and Dr. Limaye, for your presentations and insightful answers. We will email the links to the resources mentioned today and shared in the chat. With that, I'd like to say thank you again to everyone for joining us today.